Cases and Controversy. And today it's my great privilege to have my mentor, Dr. Jeffrey Moses, who serves as Director of Interventional Cardiovascular Therapeutics at Columbia University Medical Center, as well as Director of Advanced Cardiac Interventions at St. Francis Hospital and Heart Center in Roslyn, New York. For his entire career, he has relentlessly pursued perfection in interventional vascular techniques and is a role model for generations to come in this ever-changing subspecialty of interventional cardiovascular medicine. He was C3 Lifetime Career Achievement Award winner in 2010, besides numerous other awards in his career. An internationally recognized interventional cardiologist, Dr. Moses serves as professor of medicine as well at Columbia University Medical Center and has performed more than 18,000 interventional procedures, authored over 600 publications, and served as lead investigator for numerous national and international clinical studies. They have demonstrated the effectiveness and safety of coronary stent placement. So without further ado, I'm going to turn over to Dr. Moses, who's going to share a case. We're going to discuss it, and we're going to have a lot to learn this morning for the next 45 minutes to an hour.
Okay. Well, it's great to be here. And let me get this case up. Raj, thank you for doing this. It's a wonderful effort, and to continue the clinical education of our group as we miss live meetings, which, by the way, are starting to come back, thank goodness. So if you haven't gotten vaccinated, get it, and we'll be able to interchange in person. So should I start the case?
Absolutely.
Okay. So I was asked to give this case about how imaging changed my my approach in a given case, and I think this is a good example. I did this with my good friend Richie Schlafmitz. It was actually a transmitted case, and no one was more surprised about the outcome of this case than we were. So this is a gentleman with 75, usual risk factors, has heart failure. He presented with dyspnea on exertion, and which was exacerbated in lower extremity edema. He had an EF that had recently dropped from about the 30s to 15 to 20%, and he underwent a diagnostic catheterization. Here is, of course, his here's his left ventricle, as you can see, which is markedly diminished and diffusely hypokinetic. Here's his coronary angiogram. This is the right coronary angiogram, which is right dominance, but nothing extraordinary here. He has all the usual equipment for someone with a low EF. Here's the most telling part of it, the most formidable. As you can see, here's his left coronary. Here's his left main. There's multiple calcific nodules that we're looking at here at the bifurcation, including what looks like a very large eccentric calcific nodule extending from the left main into the circumflex, as well as a lesion in the ostium of the LAD, and also it looks like a lesion just about 10-15 millimeters distal to that, in this with a very large circumflex, as well as obviously a large bifurcating LAD. It does not appear that there's much distal disease in either one of these vessels. So do you want to?
Yeah, so let me pull Dimitri from Greece.
Oh, okay.
Dimitri, what do you think?
Hello, good morning. Good evening, actually, from Greece.
Yes.
I'm very happy to see Dr. Moses again in the panel. We are waiting for him again in Greece.
We're anxious to be there. Trust me.
I can see, as always, this is a difficult situation, a really tough case. Bifurcation, always. Bifurcation, actually, it's my love in interventional cardiology. I don't know. I think usually in these cases like this, I would prefer to have imaging, or absolutely an imaging evaluation of the whole situation to see all the anatomic features, to see where the plaque starts, where the plaque stops, to see the angulation, to see the distribution of the plaque, to see the conformation of the plaque, to see the constitution of the plaque. I think we have several to learn using imaging evaluation in these cases. To my point, actually, to my view, I think using imaging techniques in these cases, like this one, I think adds really significant help on how to proceed. I will stop here and like see if there is any
physiology to determine, whether LAD is significant or not.
Can I make a comment on this?
Yeah.
I can see that at least circumflex looks really severe. So if we're gonna deal with the circumflex, I think we have to deal with LAD in the left main from the beginning. Therefore, I would say that there is no need to do any functional evaluation of the significance of the coronary disease in the LAD, since we have to deal with this. I would say that we have to go straight forward and see how we're going to treat this lesion.
Yeah, in terms of the imaging, Dimitri, in your lab, would you IVUS this given that it's so calcified, or would you pick OCT, and what parameters would you use to determine the significance of the disease?
To my point of view, I would prefer to have an IVUS. Actually, I don't believe that IVUS we're going to cross this tight ostium of the circumflex. However, we could do a small pre-dilatation of the circumflex and then put the IVUS, check the left main, the distribution of the plaque in both lesions, and see how we're going to proceed further. IVUS is my favorite, and as I learned from my mentor, IVUS is always tell you how to treat the lesion. FFR tells you which lesion to treat, and OCT tells you how you treat it. So I would do IVUS.
Yeah, I think that OCT would also really give you a great plaque morphology here. Given that it's so calcified, you're going to be able to see much better with OCT and determine the size of rotational atherectomy, but if rotoblader was chosen. But it's always hard in left main sometimes to inject enough dye to get a good clearance. But let's ask Dr. Moses that what was done at this point.
Yeah, well, first let me just tell you this. Looking at this just as the angiogram, and that's I think an important point of this case. We agreed, and we thought that if just angiographically there was a moderate lesion in the LAD, but the ostium of the circumflex and the LAD just concerned us greatly. And of course, with the distal left main plaque also with that big calcific nodule, looks like extending into the left main. So we decided, because of the complexity of this and the coronary anatomy and the unpredictability with the need, what we thought was going to be atherectomy, in our case, we would have favored orbital. We actually decided to put in a left ventricular support device, an Impella, because we really thought we were going to be committed to a bifurcation stent. And with all the vagaries of bifurcation stenting and issues about recrossing crossover stents and putting in the second stents, we felt with this type of support, hemodynamic support, we could work in a much more controlled manner. But we were definitely, I agree, very concerned predominantly by that circumflex nodule, with a real dilemma on how to treat it. And we don't have any really good answers to that. But of course, the first thing we did was image it. And I think I've learned, especially in these type of lesions, you never know what you're going to see on the imaging. I mean, despite all your preconceived notions and your level of certainty with the angiogram about how you're going to proceed, it's invariable that you get some new information that you didn't expect in these type of cases. So we went with OCT, and I'll tell you, obviously I've done a lot of IVUS in my life, and we love IVUS, but I think in the OCT in these calcified lesions gives you the advantage of obviously giving you the depth of calcium in a much clearer picture. And we've worked with these algorithms at Kiko, and actually a lot of data that came out about Columbia and St. Francis, looking at an algorithm, really anticipating when you actually need to perform more aggressive preparation techniques. And a big part of that component is thickness. And obviously IVUS doesn't give you thickness. Now there have been developed some IVUS-based algorithms as well, but we think the OCT one is just simpler. It's sort of the rules of 50s. It's like 50%, 180 degrees, 5 millimeters, and and 500 microns, a half, millimeter thickness. And those are the things that indicate the need for atherectomy. But here, and let me just start this again, just a rapid run through. Here we are. You can sort of see the distal LAD, the distal lesion of the LAD. Now we're coming in towards the ostium of the LAD and the bifurcation and into the left main here. There's the distal left main. And I'll show you this in still frames, which will be a little easier. Here's the distal reference, which actually you can see the area here is aneurysmal and it's large. And here we are where we thought there was a lesion, but the area here, as you can see, is actually 4.6, which certainly is, if you sort of translate that into IVUS, it's like being over 5 if you do sort of a mental change. But here we are is in the, the complex right by the bifurcation of the left main and the LAD. You can see a very eccentric calcific nodule here. And with an area, again, here the area, of course, is in the distal left main is 4.5. And up here's the proximal reference. So what we see here is at a little less disease than we anticipated. It's really focal just around this complex of the bifurcation of the LAD and the left main. But then, of course, as is necessary in all these bifurcations, we independently image the circ, especially given we would do this even if we weren't as concerned about it, because it's just the size of the circ and the angulation. You can also anticipate compromise and a need for a potential second stent or a kissing balloon. So here we are in the circumflex. Let me just run this again. Here we are coming distally. And as you can see, we're going to be getting up towards the proximal area, towards the ostium here. There's an eccentric nodule here. But when you really break it down here, here's our distal reference again, a little aneurysmal there. But the ostium of the circ, and trust me, we were in stark disbelief on this. Okay, we probably rolled back every single frame, but we could not. This was eccentric. There's your nodule here, as you can see. But the area was really over 6 and really not critical. And believe me, we were doing a live case, and there was a lot of skepticism about this, including by us. But, so here suddenly, and as you focused on the circumflex, Demetrius, and so did we. But interestingly, you got to, it's like, what are you going to believe, me or your lying eyes? This is what it is. And here, of course, is the nodule in the distal left main, continuing distal left main. So we were pretty astonished, but in a way, pleasantly surprised in terms of this radically changed, obviously, our approach. I don't know if, I guess Raj is on the phone here. I don't know if we have any. Okay. I guess I should go ahead with the case here. Anyway, so
can I ask
now,
something, Dr. Moses?
Yeah, I'll hear you.
Can I ask something before you continue?
Yeah.
So in that case, so it's really surprising. I mean, it's nice for the patient actually that there is not a critical lesion there, even though geographically I would bet that it is more than, let's say, 80-90% stenosis. That's amazing.
I know.
However, since you see that there is not critical stenosis, and there are two important factors here, is that there is a distribution of the back which is not good, absolutely. Yeah. Eccentric lesion, calcified lesion, ostium circumflex with let's say vertical, I would say, origin of the circumflex. And the other one is that all the plaque is distributing from the circumflex towards the left main. Should you consider this in this case to perform now functional evaluation of the lesion? I mean, it's it's a 6 square millimeters. However, it's more than 50% of the square area from the distal reference. So should you perform a functional, let's say, evaluation?
No, I mean, I think an area this large, especially in a focal area like this, especially in a circumflex vessel. I mean, an LAD, you can never tell. You can never rule out hemodynamic significance in the LAD just because of the variability and the amount of myocardium these lesions can serve. I mean, an LAD 6 could be, or say a little lower than 6 could potentially be the equivalent of a left main in terms of its distribution. But I think for a non-LAD vessel, I think a 6 in a focal lesion, I think a hemodynamic assessment would be, I think, redundant. Okay, I mean, we could have done it, but I think 99% it'll be negative. So, of course, this doesn't take away the fact that you can see this, very eccentric nodule in the ostium, and during our manipulations, who knows, what kind of carinal shift or plaque shift you could get. So it doesn't get you off the hook here, as you'll see, as we're meticulous about that. But the other question that emerges, though, is when you have these, eccentric calcified nodules, which, as we focused on them more and more, we've seen some very peculiar outcomes with these, especially in terms of intermediate outcomes of the calcific nodules actually re-protruding through the stents and literally in short order and causing really refractory stenosis. And there are some case reports about it, and causing stent fractures or just protrusion into the plaque, literally within days or weeks afterwards. So they present a special problem. And I'll put it to you guys, what's your treatment of choice for these calcific nodules?
Yeah, I think that this, calcific nodules is a problem. And I actually seem to agree with Dimitri that, I would have probably done functional evaluation first before I would have done, imaging. And because that's usually what my personal algorithm is. This is fine to do it this way, but I still think that maybe, a case like this, if I had to do something in the circumflex, I would say that either a rotoblator or an orbital atherectomy will have to be done, because otherwise, this nodule may just protrude, to the other side and may create a lot of problem in that stent jail.
Mm-hmm. Yeah. So, I mean, those are concerns. And, we generally tend to lean, frankly, towards orbital, only because, we can, if the wire bias especially is more again towards the plaque. And I think, let me see if I can go back to the, here, for instance, in the B panel here, I'm actually going the wrong way here. Sorry. I don't want to get ahead of it, but here is the look at the lesion here. We have there's a bias towards it. You see where the imaging catheter is. So we think with an orbit, especially if you went on to large, you could really maybe shave off a larger segment of this than say with a rotoblator burr, unless you used a very large burr. So I just think that we tend to favor that. But in this case, what we did actually, and really not knowing what to anticipate, but we had a distal reference of 4. We actually took lithotripsy. We actually put up a shockwave balloon. I'm not necessarily recommending this because there's a lot of controversy, and I was hoping Carlo would be on. I don't know if you've had Dimitri.
I was just talking to him on the phone. He's getting on in a couple minutes.
Yeah, I mean, I'd love to hear Carlo's comments because he has, an enormous, long-standing interaction and assessment of this technology, along with very great expertise in OCT. So I'd like to hear what he has. But we did chose this thinking that if it didn't work, we still had, orbital or rotational atherectomy available. The lore is that, this technology works best in, in circumferential calcium, because without it, the waves dissipate into the soft tissue and it's not that effective. The good news here is obviously, you keep this up for a while. It's not a perfusion balloon, so you're keeping it up in the left main. So, we did literally 8 cycles of 10 pulses with this. And I mean, the nice thing here is you see the heart is still beating while we have the balloon inflated. And I think that gives you the security of actually having the hemodynamic support here, because I don't know how you could even approach this technology in this type of lesion without the hemodynamic support.
So Jeff, for technical purposes, would you not use the same? I don't know whether you had given all the cycles of pulses in the LAD, but otherwise you could have probably put the same balloon in the ostium of the circ and give some energy there too.
Well, we definitely could have, but I know, but we did not think it needed treatment because of the lumen. I know that's it. Believe me, it's very seductive. And during the entire case, I promise you, with the panel, everyone was giving the same reaction. It's hard. You really got to have faith in your imaging in these situations. It really tests your faith in the technology, as opposed to saying, well, I'm going to stent it anyway, which, by the way, which was very tempting all around and very seductive. But anyway, here we did it. And you can see on the right panel, I think you can get a sense that the ostium of the LAD here, the circumflex, the ostium of the LAD looks much better, which, was surprising. And then, of course, we did do another OCT run. And here's the pre and post, sort of the slightly distal to the LAD. Here's the nodule and the area, and here's virtually the exact same area. And it actually went from 6 to 9, and here the tight area, which was about 4, and it went up to 8. It looks to me like we have a big crack here. You see that?
Yep.
I mean, so we were actually pleasantly surprised to see. Now, look, is this from the shock wave or is this from the balloon? I'll leave it to you. But we were actually, whatever the effect of this was, and we do believe this depth of fracture had something to do with the energy, the energy brought into this calcium, and we were very pleasantly surprised. So we thought we sort of mobilized the plaque much more than we anticipated in terms of our ability to further manipulate it now with balloons and stents.
Now, there is another lesion just distal to that, even though that was not critical. Was there any energy delivered there at that point?
No. I mean, we have this discussion all the time. I believe stents are not for treating disease; they're for treating obstruction. And I'm trying to get the flow dynamics normal. So my philosophy is, if this does not constitute something that would be problematic for the outflow of my anticipated stent, I generally don't treat it.
Okay.
Yeah. Okay. So, okay. So now, after seeing, again, because we're still worried about potential plaque shift, we did re-image the OCT. Again, as you can see, we're very anxious about this and we need constant reassurance. And here again, the lumen area hasn't really changed. Again, right at that spot that we're all concerned about, it's persistently open, and we don't see any dissections here or the like. So we actually decided to proceed. At this point, we had the confidence of a crossover, and the nice thing about the shock wave is we don't have to test it with a balloon, right? As you would. I mean, if you saw this after, say, atherectomy, you still might say, well, before I put my stent in, I'm going to test it with a balloon. But here we went directly to a stent 23, which was measured off of the OCT, as you can see, into that area that you had some into the aneurysmal area all the way back to the left main. We deployed that, and then based on the size of the left main, which was approximately there 5, here we are placing the this is we're just placing the balloon for the pot. We don't have the inflate, but here we are moving things back and actually placing the marker, obviously, at the bifurcation of the circumflex. So we did the crossover. And here we'll see, then of course we did the OCT again. This is very interesting. Here we see areas of malapposition, which I'll ask everyone to comment on here. I mean, we were very happy with the results, but again, it's very complex. We have this, let me show you the still frames here. But as you can see here, here's the area of the ostial LAD, and the actual area, obviously, of the stent is around 8, but you do see this malapposition out here. And this is that, I think, that big gap off of the, eccentric nodule. And there was a lot of controversy about what we should do about this, because obviously you could take a larger balloon and maybe move the 5.0 in here. But I just like to get these struts opposed, even though the luminal area of the stent itself was actually terrific. And the distal left main, as you can see, the area is, almost 13. So we're not upset. But this was an area of some concern, and I'd like to get your guys' thoughts about this, or even the audience's thought about this.
Yeah, I'd say I don't know whether I think that even if we post dilate this, that this is going to get a lot better, because I think the oblongity is because of that calcium, and maybe might get a little bit better, but it's definitely not going to look round like this, like what you're seeing in the distal left main. I think this will remain. Also, the distal portion of the stent also has a little bit of minor malapposition, but it's not significant.
Yeah.
So I guess, yeah, we could put a 4 or 5 balloon in there and go at a high pressure. We don't have those very high pressure balloons in US. They're available OUS, like an OPN balloon. That could be of help here. Dimitri, what would you think about doing an OPN balloon here?
I don't know. This is a difficult situation now.
Yeah.
That's why I thought from the beginning that I think that we should have done a proper ablation. I mean, as Dr. Moses already said from the beginning, that using the shockwave balloon wouldn't be probably the best solution in this case. And I would anticipate something like this, because this calcium nodule would prevent the balloon to circumferentially touch the vessel wall and crack the calcium. I'm not sure. I don't think that, as you said, Raj, if you do further dilatation with high pressure balloons, we do this thing much better. And I would, to my opinion, I don't know, I would probably check if there is some protrusion of the plaque from the circumflex. So I would like to see an OCT from the circumflex towards the left main, and see if this is probably a protrusion of the plaque from the circumflex. Do a kissing balloon, rewire kissing balloon, a new pot, and see how this plaque will change. And eventually I would probably do a reverse block.
Dilate into the circ and create a space in the stent to push the OCT catheter down. Otherwise, you're going to have a lot of friction. There is a question from the audience, Dr. Raff from Emory. What about using scoring or cutting balloon after IVL, but before stenting?
Well, our thought here is we saw that big fracture, already in the middle of the nodule. And so I didn't know whether, cutting or scoring would make any further difference. We don't know. I mean, this was just, frankly, our first use of this technology in this entity. In terms of atherectomy, though, I mean, as I said, we have favored orbital, but we just see what we see with these is, I mean, you don't really have huge ablations. What you do see is some polishing, really in an eccentric manner, depending on the lie of the burr or the orbital atherectomy device. So we don't really get massive decrements in the plaque volume. We didn't feel that this was a bad result. We thought actually just fracturing it and mobilizing it, we actually were very positive. Our concerns here, and there's a lot of back and forth on this. We sort of think of this, think of a big calcific nodule on a aortic valve when you're expanding, a sapien into it. And on the echo, you sort of see that nodule sort of just impinging a little on the aorta, right? That's something you don't post-dilate, right? So we sort of took this as along those lines and really, and I'm not saying this is the right decision, but given the fact that this is the LAD with an area, as you can see, of 8, we had we had very good flow here. We have a good area. We're not really worried about thrombosis, despite the malapposition, which I don't really pay that much attention to, except on the inflow of stents for future access, either immediately or later, because you don't want wires getting caught behind it, except for tacking up those osteal areas for future access. Malapposition is really per se has not really shown to have any adverse effects. So we actually did not further dilate this. We were actually happy with this. But as you were saying, in terms of the circumflex, we were, again, perseverating on this. But interestingly, Raj, in spite of what you thought, we just crossed directly with the OCT. I guess our struts were perfectly positioned. We planned it that way, So the cell was perfectly over the circumflex, and it just went like a breeze. I mean, it was a surprise. I was working with Richie, and he just did it. And here again, you'll see here. Let me just go back to the beginning here. Here, let's do the pullback here. Again, it was a shorter pullback, obviously, towards the ostium again. And let me see, we should have a still. Well, we don't have the still frame, but anyway, the area was still around 363. So it didn't change in spite of all this. So with that large area, frankly, and the ease of access with the OCT, and the fact that we had an eccentric nodule there that we were really concerned about, extruding and perforating or potentially extruding it through the stent struts, we stopped there. And I think the lessons we learned was, imaging can radically change your decisions. And you just never, with calcium, you just never know. You just never, anyone who points to an angiogram and knows exactly what to do with calcium, obviously has never done intravascular imaging. The patient did very well with this.
If Dr. Moses, if I may make a question.
Sure.
This is something I'm always thinking, and I don't know whether it's correct or not. I mean, I was always thinking that doing a lithotripsy, a shockwave ballooning bifurcation, does the wave, the crosstalk wave, moves towards the bifurcation itself, or just stays in the main vessel, the vessel that do the shockwave? And I would say that probably in this case, could the shockwave could crack also some of the calcium, some of the calcium circulating the ostium of the circumflex? Could this be possible?
Do we have that? I mean, I don't. Carlo may have a better understanding of the physics of the wave itself and how far it's effective and how the pressure wave goes. So Carlo just came on, and he's one of the world's experts in this. And hi, Carlo. So I'll let him answer that question, and I'd like to learn that answer too.
So Jeffrey, they say 10 millimeter is unfocused energy. Of course, reduction of energy is quite rapid, sort of exponential from the site the balloon reach. So there is a good effect on the inner wall close to the balloon site, while if you just move outside, I don't think that you will get much periadventitial. However, which is good because we don't want damage, of course, to nearby structures that are not cardiac.
Okay. So and actually, if you see the OCT, there really was no disturbance in the ostium of the circ at all. So I guess that verifies the modeling that's been done with this technology. Yeah. So Carlo, have you been watching this at all, or you just got on?
Well, I'm sorry, but I just managed to get on. I had a few issues with connection. Sorry.
Yeah, we all have that. Just so no, my question is, we just applied this IVL to an eccentric calcific nodule, and we didn't know what to anticipate. We really did it for our own understanding of the technology, because obviously we just got the coronaries here a few weeks ago in the US. And I'd like to hear, certainly like to hear your comments on your thoughts about that and your experience with it.
Well, I think there is a big difference between an eccentric calcification, so a plate of calcium, subintimal, eccentric, less than 180 degree, and the protruding nodule. I think the first one, the response to lithotripsy is, I would say, as good as with concentric lesion, which is the difference from rotablation, where it all depends on the way the wire bias leads the burr to touch. Will not damage normal wall, but if it doesn't touch the calcium, there isn't much that will be accomplished by rotational atherectomy. And a little bit the same with orbital, with the caveat that, of course, is a larger area that is explored with the diamonds. With the lithotripsy, I think you can get good result in eccentric lesions. There were at the start some reports that you get less OCT fractures. However, we know that microfractures are not visible with OCT, so expansion is the same with or without visible fractures. So I don't think that's a relevant finding. I think a completely different ball game is the protruding nodule. Very thick protruding nodule. I don't think we still have a fantastic technology. I'm from Europe. The only 2 cases that I managed to do with some success were done on a compassionate basis with orbital atherectomy 2 years and 1 year ago. So you are teaching me what to use.
So we're working in opposite directions.
Exactly.
Orbital was our default, and we got the IVL and we tried it. You're just getting orbital there now.
Well, because I trusted you, you know, I asked he told me orbital, do orbital, okay?
So there is an audience question from Dr. Huma. What has been the most effective strategy for plaque modification for eccentric calcified nodules, especially in context of bifurcation lesion, which is what we are seeing here?
Well, first of all, I think, you know, the large calcified nodule is not much in the area of bifurcation. Over there, my gut feeling is that most of the time you do have the other type, the sheet of calcium that, in my view, is an excellent indication for shockwave. So if you want to use a technology to break the calcium without going to 25, 30 atmospheres, obviously damaging also the ostia of your side branches, I think shockwave is perfect, also because unlike rotational or orbital atherectomy, you can keep wires in all branches. Nodule, protruding nodule, as I said, is somewhat different, but well, then most of the time is in very large segments of proximal arteries. And fortunately for me, I never, hardly ever found it truly at site of bifurcations.
Yeah, this is it. Yeah.
Carlo, would you like to share your case now?
Right, but I'm a bit ashamed if after having seen such a good result.
Carlo, you never leave the room without a great result. Come on.
Okay. Well,
All right, let me stop sharing my screen here. Let me, how do I unshare it? Stop. Oh, here we go. Okay, I'm off. It's all yours, Carlo.
Do you start seeing something?
Yeah, we see you.
Yeah, we're great.
Your slide.
Excellent. All right. So as you see, it's a quite a recent case, September 24, not long ago. And I try to find something a little bit complex, just to tell me which mistake I did and how to avoid. I think, as always, especially in these coffee, small, intimate settings, is important to learn lessons and avoid complication rather than show super beautiful results. These are good when there are 2,000 people and you like, it's sort of triumphant applause at the end. On the contrary, this is not the case that will reach it, I'm afraid. So he's an 83 years old gentleman with multiple risk factors, including diabetes. Not the best treated diabetes. He had already endoatherectomy 2 years before and left the room with a minor stroke, fortunately full recovery. The symptom was different from chest pain. He truly had breathlessness, complete left bundle branch block, and this very poor ejection fraction. We didn't do MRI. However, the impression was that there was nothing dead. There were no Q waves in the ECG, and there was preserved thickness in all walls with a sort of diffuse hypokinesia, except the inferior wall. As you see, he was on a quite complete treatment and expecting to find lesions. They already started him on clopidogrel, that in Europe at least we have available also in combination with aspirin. Here it is. That's the lesion, which I think mirrors a little bit yours, but is almost a trifurcation. In fact, there is, as you see, a very short circ and this relatively large marginal branch, early marginal branch with the left circumflex, which is quite small in the well-developed right coronary artery.
Carlo, compared to this, my lesion was a type A lesion.
Well, this one doesn't move, but all the others I'm sure will do. So I went right radial. I use a slender. And I managed to get a 407 French EBU for the left coronary. And then I placed a few wires, in fact, 2 wires. You see the calcium. I mean, I don't know how much you could see before. Yeah, I should have shown another lesion, another image before. And you see that the impression I had was that the shockwave was expanding, but honestly, I used a single balloon 3.0 from here to here. That means almost no overlapping. And I may have missed something of this super calcified segment. I have a wire in the marginal branch, as you can see. So
just
then,
Carlo, to educate
yes.
me, when you're going back, do you size the balloon to the sort of the lumen and the plaque content, or is you move more approximately? Should you use a larger?
Yeah, you already spotted the mistake. Of course, it's a too small shock wave.
Oh, okay.
You need a bigger one. I mean, it's I mean, sorry that you didn't see the image in motion. Was a small vessel, the LAD, so
Okay.
probably 3.0 was adequate, but certainly proximally was 3.540.
Okay.
The point is that sometimes when you have to spend these 2,400 euros and you have to double the cost for 2 balloons,
Yeah.
you think twice, and that's maybe wrong.
I don't know. In the US, it's twice that. We think we're 3 times.
Right. Okay, so this is the stent, and I thought, okay, well, it's expanded and it's good. In fact, you may see an area that was not fully expanded here, and in the other view is basically where the knee of the LAD is. So where the artery most of the time changes from 3.5 to 3.0 or smaller. And then you say we place a larger proximal stent, and we concentrated on the, well, we went to high pressure with the 3.0, and we felt that it was reasonably well expanded. So far, there is no imaging, okay? So 24 atmospheres, 3.0, and we saw this, and we said, all right, it's good enough, let's work on the bifurcation. And we still have to do our imaging. So we place an 18 millimeter stent. We added the balloon for the double crush kissing, and we expanded the balloon 4.0 to crush the stent minimally protruding into the LAD, and sorry, into the left main. In this case, was a fairly short left main. You see how thick the calcified plaque is over here. Beautiful. And how it continues down the LAD all the way. And then you continue working on that, placing the stent for the LAD after having done first kissing, 3.035, don't know why so small, and then 4.0 science stent, recrossing, and 3.5, 4.0 final expansion. So this is 3.5 at 20 something atmospheres, and then I inflated together 4.0 and 3.5. So classical double kissing crush. And here it is, they look well expanded. So obviously for me, the focus was the bifurcation, also because it was a fairly complex disease. Still, there was a patency of the true circ. And at this point, I went with, in fact, was IVUS, not OCT. And I saw this area that didn't expand fully, and was actually 4.5 millimeters square. You remember, it's exactly where you saw that area not completely expanded, and 3.0, in fact, proved to be a little bit too small. I went 3.5, measuring surrounding area, also not maybe matching the distal vessel, that was probably 275. So 3.5 at good pressure. When I use this OPM balloon, I don't use it like a bomb. I do it very slowly. I grow 2 atmospheres at a time till I see full expansion. This is not exactly full expansion. It expanded a bit more suddenly at the end. I had a bit of a bad gut feeling at that point, despite the lithotripsy, and yeah. Right. So, okay. Well, I mean, in fact, it was a little bit complicated because, okay, I inflated the 3.5 quickly, and you have a 7 French. In fact, even with a 6 French, with the Bentley cover stent, you can go side by side, provided you had a second wire. In this case, I don't remember exactly if I went on a second wire. I guess no, because I see one here. And I had then some accumulation of blood during my maneuver. And as you see, I had the impression to have covered, but the very distal end of the perforation is still uncovered. So that took a little bit longer, too long for the patient that at that point lost pressure and required massage. I had to go with a second shorter Bentley, which landed in the right position, and that finally solved the problem. At this point, you have everything expanded at the price of having also with the drug elution outside two stents that have some polyurethane, and we don't know much about very long-term outcome of this particular stent. However, the reports so far are quite favorable, and definitely there is a good distal flow. The artery at the start was not that much smaller. Of course, a little bit might be the norepinephrine that was at this point running, and obviously I had also to get out 350 ml of blood from the pericardium to get restore a full functioning circulation. I mean, the patient had everything. Advanced age, well, was a man. There was some renal impairment to start with, severe coronary calcification, plus we required high pressure stent post dilatation. I trusted a little bit too much shock wave. The way, honestly, I most of the time do when I have a segment longer than 30-35, I go with two shockwave balloons, especially if, like in the LED, there is difference in caliber, because the quality of your final result will not be the same having an undersized balloon. I think that I've been heavily punished for that. Fortunately, more me than the patient, because he did all right after that, required renal replacement therapy. We had, because of the poor left ventricular function, to keep it in hospital, implant a CRT ICD. Together with Entresto, he stayed in hospital almost 3 weeks after that. We discharged him home with a better ejection fraction than he came into hospital. I don't know whether without this complication was due to...
I think we lost Carlo.
Yes, so while we're getting back, one question from the audience is that instead of OPN balloon, would you have considered using lithoplasty to expand the under-expanded stent segment? That could have been a better alternative. I don't know whether the trackability of the lithoplasty balloon, whether it would get there, but.
Well, I mean, unless I'm mistaken, I don't know where Carlo went, but I thought he had originally treated that area with the lithotripsy before, but he felt, I guess, it was a little undersized. I was actually going to ask Carlo how he chooses between the OPN and the lithotripsy, because lithotripsy is probably somewhere around 60 ATM. And I mean, they rate these OPNs at 40, but I know people who take them up to 50 and 50 plus. So the question is, you know, what technology do you prefer? And does he think lithotripsy is a bit safer because of the way it gives multiple fractures and maybe gives a more symmetric expansion of the vessel, and maybe avoid this?
You know, before COVID, you know, when, you know, we were all traveling, you know, the most of the cases of the lithoplasty that I had seen in the Europe, they were associated with some form of rotational atherectomy. So they would do a rota, you know, and then they would do a litho, especially in a very, very tough, you know, severely tight stenosis. And that's you know, potentially a good strategy for such a diffuse thick calcium. Hi, Carlo.
Hi.
Doesn't like me. Twice.
That's okay. We were talking about, you know, whether you could have used an IVL to expand the under-expanded stent rather than an OPN balloon.
I think it is a good point. I think, of course, it's not something I would recommend. I think you should do a good pre-dilatation and use your, make sure that you have full expansion. I think the second mistake was to do the ultrasound imaging after being implanted the stent. It's better to check that there are proper cracks and so forth. Also, not always you have a complete understanding of that, but sometimes going with a high pressure balloon before a long high pressure balloon, you see good expansion and that's a good way to check result if you really want to spare on imaging. I agree that with a 3.5 shock wave, very unlikely to happen anything like that. The only thing that you may risk is to somehow damage the coating of your drug-eluting stents, and people say microfracture in the metal, also not full thickness fractures. So it's not something the company recommends, it's not something I think we should do as a routine, but probably was a much better idea. Once I did the mistake to use only one to start, at least complete the work with a bigger one.
So we have a couple questions from audience. One question from Dr. Kukkel Seaman is, what are the predictors of outcome after lithotripsy regarding early and late follow-up, either by IVUS or CT or just an angio?
So predictors, we have a study now in 628 lesions, the meta-analysis, all the 4 disrupt registries, which has just been submitted, but I don't think is, I think I'm allowed to anticipate some of the results. There are at multivariate analysis, only 2 predictors of MACEs, but I may remind you that in all the 4 trials, 628 lesions, there are only 2 perforations after stent implantation. So a little bit similar to this mistake. There is 0 after lithotripsy. Okay, so lithotripsy really is a way to prevent, not to induce perforations. In terms of MACEs, that means 90% periprocedural myocardial infarction, greater than 3 times increase in CK and B. Length of the lesion predicts it, 1:31 odds ratio, every 10 millimeter of increased length, and you start with an average of 25 in the trial, and bifurcation, and you increase by roughly 1.6 odds ratio. These are the only 2 significant factors.
If I may make it just a technical question, Raj.
Sure.
Yeah, most of those lesions, apart from calcium, they contain a lot of fibrous plaques. So more and more lately, we're using the rotacut technique. So we use rotablation, then we do a cutting balloon. Would a cutting balloon, let's say, could offer some protections in this case, like yours, Professor?
Well, I don't know. I think that the best way is always to know what you do and to do imaging before. So I think that I've been asked to show a lithotripsy guided by OCT showing an unguided complication maybe was not so good from my side. Of course, if you see, I have a couple of examples, one in a nice vein graft that I did recently, that you have an area of under expansion after shockwave. You check with, in that case was ultrasound again, and there is an eccentric calcification. You see, in fact, some ruptures there. So obviously is on the opposite side where there was a concentric lesion, half calcified, half not. And then I went with the cutting balloon. I think the cutting in general, done blindly, I'm not so sure is so helpful.
We have one last from audience, Dr. Alomar from UK. We have had 2 or 3 IVL balloon ruptures, and we suspect this may have happened because of significant undersizing of IVL balloon to the vessel size. Can you comment on that?
Well, I don't think that there is much to do with over or undersizing of the balloon, IVL balloon. First of all, is a phenomenon that we saw in a certain particular time of the history of this technique when they tried to thin too much the balloon. Right now, it happens quite rarely to me. I won't say that doesn't happen, but it's maybe 5%, 10%, and hardly ever at the start. If you do your first dilatation in the same spot, will never happen. Believe me, at 4 atmospheres, you don't rupture these balloons. What happens is you rupture when you have distorted a little bit their geometry and you pull it back and the calcium cuts them. That's the way it happens. And then even at 4 atmospheres, they may rupture. Of course, there might be some adjunctive effect coming from this powerful sound that generates shock waves, and some damage to the wall is understandable. However, the company says that they are coming with balloons that will withstand more than 80 erogations of energy. So my expectation is that that will be the case. Consider that at 4 atmospheres, the rupture is of no potential harm, because you don't rupture, an OPN at 40 or at 50. Even in those cases, may be harmless. It depends how it's broken. If it's a pinhole that sprays the contrast outside, it might be an issue. But if it's broken like linear, not much happens. With this balloon at 4 atmosphere, I see nothing wrong. The only thing which is wrong is that you have to pull out a second balloon, which costs money.
Yeah. Dr. Fahim Jeffrey from Singapore has one question, and I think that then our time is up, so we'll stop. That if you had done an imaging and if you had seen an eccentric nodule there at the site of the perforation, would you have used an OPN balloon?
Well, I think here probably the issue is that being sure that the vessel is truly 3.5 when you have already stented everything is not so easy. It is not easy in all cases when the vessel looked very small at the very start of the procedure. I'm sorry, that was a steel frame, but I think you could understand that. Probably doing an IVUS at the very start, I was measuring 2 millimeter distal, which usually was undersized. I think that you probably have to exert some more caution. Even if you go with a balloon like OPN, the reason why I like it is not because it goes to 55 atmospheres. Myself, I hardly ever went to 55 atmospheres. I like it because truly doesn't grow. And I believe is almost the only balloon predictably staying of that size with minimal change at very high pressure. However, if you select a balloon that is slightly wrong and you go at that pressure, everything may happen.
Any final comments from Dr. Moses?
Yeah, well, I think it's interesting because I think the message here is if you can image, use it up front.
Yeah.
You already spent the money and you work with confidence, So, and Carlo, who's been imaging even longer than I have, which is extraordinary. But I think that's the message, I think.
Yeah, I was obsessed by that bifurcation and knowing that it was complex and so forth. And in fact, it was the easiest part of the procedure.
We're all human.
Yeah. Dimitri, any other comments?
I think it's more and more we are going to deal with this kind of lesions. We have to prepare. We have to be comfortable with all the technologies, rotablation, orbital, and most important, the lithotripsy balloons. As we're getting this technology more and more, we like it very much. I think it's going to change our practice from now on.
Well, thank you very much, everyone. I want to first of all thank Dr. Moses, who's taken time out of his very busy schedule, and Dr. Carlo Di Mario from Florence in the evening. Thank you very much for, despite difficulties in connecting at the right time and presenting a fantastic case, a lot of learning. I want to thank all the audience. We have audience extending all the way from Singapore to Indonesia, China, India, pretty much a lot of Asian portions today, as well as a lot of people from domestic US. So I want to send a good evening and best wishes to everyone in Asia today who has joined us, and as well as have a great weekend here in US. I want to thank all the attendees. We look forward to having you again on May 10th for the next edition of Coffee, Cases, and Controversies. Thank you very much.
All right, good seeing you, Carlo.
Thank you.
Thank
Bye.
you very much. Bye-bye.
Thank you.